Well, thank you everyone for coming here. We are in the session with Dr. Jacqueline McGrath about playing in the NICU. My name is Yamile Jackson. I'm going to be your moderator also with Marie. I am a mother of a former preemie that was in the NICU for 5 months. I also have 4 engineering degrees. My PhD is in ergonomics and human factors engineering. And so after Zachary was born, I switched my career to helping families and babies have a better stay and better outcomes from the NICU. So my son is 20 years old. He's in college. He's doing great. And these sessions are part of the Kangaroo Care Day initiative that I started in 2011. I hope everybody here celebrates Kangaroo Care Day on May 15. A little bit of trivia. May 15 is because my son's birthday was May 15. So it is a pretty special date for me. We are going to have a couple of minutes, 10 to 13 minutes with Dr. McGrath. She's going to present. Then we're going to open up for questions. And this is an informal session. So, you can look underneath on your Zoom screen for reactions. And if you have a question, you can raise your hand. You can also put it on the chat, and if you don't want to say it out loud, but if you ask the question, if you can, please say who you are, where what is your role in the NICU, and where are you coming from. We have people from 32 countries registered, so this is very exciting. So I'm going to let Marie introduce herself, and she's also going to introduce Dr. McGrath.
Thank you, Yamile. For those who don't know me, my name is Marie Boone-Clark, and I spent nearly 40 years with Me Johnson, so recognized a lot of names for those who registered. I'm now the Chief Commercial Officer for Antonia and Grace, and Antonia and Grace provides an ecosystem for of navigators who shepherd birthing people through their pregnancy journey. And we have, through subscription, doulas, lactation consultants, and the broader care team to complement one's medical care team. I am beyond excited to introduce Dr. McGrath. My role with Me Johnson gave me an opportunity to meet hundreds and hundreds of wonderful researchers and clinicians, and very few did I not walk away from with them as a lifelong friend, and I like to consider Jacqueline as one of the people. Dr. McGrath is the Thelma and Joe Crow Endowed Professor and Vice Dean for Faculty Excellence at the University of Texas School of Nursing. She has published more than 140 peer-reviewed articles, over 125 editorials and short manuscripts, as well as more than 35 book chapters. Dr. McGrath's work has focused on the biobehavioral outcomes for both parents and infants by increasing parent engagement in the care of the baby while in. Dr. McGrath has also conducted studies related to preterm infants readiness, oral feeding readiness, as well as preterm infant touching massage. It's my absolute honor and incredible joy to introduce a nurse and amazing researcher and highly respected leader, Dr. Jacqueline McGrath.
Thank you, Marie. I really appreciate that introduction, and I really appreciate that Dr. Jackson invited me to be a part of this series. I want to say that I think that play is the most natural way that children learn, and that oftentimes in the newborn intensive care unit, the idea of play is overlooked. It's felt like it could not happen there, that it's not the right environment. And maybe the way that we all think about play, that's true. But I do think there is a type of play that can happen in that environment. And that's what I'm going to talk about today. I don't have any conflict of interest to report. However, I am the editor for advances in neonatal care for the National Association of Neonatal Nurses. So that's where you might see us. This is a picture where we got like 5 seconds on the screen where our journal was used as a prop on TV. So I always love this picture, but truly we were on the screen maybe 5 seconds. The reason that I think that play is so important is that we learn by doing and we learn by interacting, and that play is the most natural way that parents interact with their children and help their children to learn. I use this picture of the brain because it demonstrates how every hand that touches that brain wires that brain, connects the ways that children do things by that touch. And particularly during the NICU, this is really important, and really important early as well as they continue to mature, because that brain, those connections are being formed. Early development, particularly in the NICU, but even into early infancy, is a time that is called a critical period of development. And critical periods mean that there's a lot of growth, a lot of change happening, a lot of opportunity to affect it both positively and negatively. And so how can we as care providers think about that differently? There's been a lot of different approaches to caring for newborn infants, particularly extremely small infants in the newborn intensive care. And many of it has been to protect them, to really say, wow, these babies aren't ready for all this light and noise and touch and how we do things. And so many places have incorporated what I would call almost a minimal touch approach. Even at times encouraging parents to hold off on touching or really providing any stimulation, and incorporating maybe less movement. Many times now we're looking at, alignment of that head to try and decrease IVH. So really thinking about that minimal touch approach, but also thinking about what does that incur. And there's a lot of arguments about this whole positive and negative touch approach. Generally, touch in the NICU is more medically driven, a little bit more noxious. And yet in the background, we have to remember that those neural pathways are developing, and how we touch helps determine how those pathways will be developed, and carries on not just in the newborn intensive care unit, but far beyond that. And then if we're only doing what I would call that medical touch, and this is my argument, those are the pathways that become more dominant. So for example, a baby that has a lot of heel sticks, the neural pathways in the heels change, and over time, they actually develop more neurons in that area. And those more neurons make that a more sensitive area. And then you can have long-term sensitivity in the heel. That's just one example that could then affect walking, could affect how the child thinks about grass, so many other things that manage. Those things are kind of happen not because we're trying for that to happen. It's just that that's the way the neural pathways develop. Minimal handling guidelines were put in place as neuroprotective, to put some kind of reason that, we need to kind of protect this baby from light and noise and touch. And yet, one thing I would argue is that we as healthcare providers justify that all the touch that we do that is medical, all the procedures, all the other kinds of touch, as we must do that. We justify that. And yet, on the other hand, say to a parent who could provide positive touch that, no, you should wait. And so for me, I've struggled with that and really studied that and thought about how the neural pathways were developing and wondered a lot about how do we make them develop more normally. In other words, if we're going to have negative touch, also kind of try to encourage what I would call positive touch so that those pathways develop differently. That's really the rationale for why I do that. And why I think about, well, why are we waiting? Most touch and massage kinds of protocols are usually instituted, if you look at the literature, after 32 weeks post-menstrual age. I think we've lost valuable time in how those pathways are being developed if we wait. And yet the rationale for waiting is we don't want to overstimulate. So there has to be that balance, that education about how parents can be educated, how they can read their infant cues, know when to move forward and when to not, but also provide positive touch. And maybe that's just touch, not moving, not just holding the baby. Maybe it's just being there and, providing a secure hands-on. It's not about really adding, it's providing more facilitated support. It's really understanding if the baby can be held in skin to skin, it might be that, but it's really doing that in a way that's very positive. In addition, I think it's also about adding some warnings. So we would never go into Mrs. Smith's room and touch her without a warning. We would say, good morning, Mrs. Smith. I want to really do this, check your vitals. Are you awake? You would talk to her. But for a baby, we don't really give those verbal warnings. We don't really help them to understand that this is going to be okay. This is good touch. And I really feel that talking to them and letting them know this is mom, or this is what's going to happen with this care is really important, because these neural pathways truly are created by experience. So if you look at some of the background, the basic principles of development, our genetic material only provides function for a small part of our genetic content. The rest unfolds by experience, the normal experience of the womb and how that the baby interacts in the womb, the normal experiences as a new infant. Those synapses, those connections are formed by experience. So, and the way I can explain experience the best way for you is that when you leave work after a 12-hour shift or a long day, and you know that you have to stop for donuts on the way home, but it's 2 exits before you normally would stop. What are the chances that you're going to pass that exit? And because your pathway has been set that this is the exit you normally get off at, the chances are pretty high that you're going to pass that exit. That is because that neuro synapse connection, that pathway has been laid down over and over and over and becomes a really strong connection. The connections that aren't reinforced with experiences don't get laid down that way, and they're more likely to break. So what we want to do is give positive reinforcement and establish those really good connections. And that is truly done by experience. The other thing that I want to think about is stress. The babies who are in the NICU, particularly at earlier gestations, their brain is still developing, and that chronic stress can really have an effect on that. So how do we decrease that stress? How do we give them predictability? In the newborn intensive care environment, most people don't talk about Erickson. remember way back and you're studying Erickson. Erickson is an early childhood theorist, and he looked at the first stage of infancy is trust versus mistrust. Well, I would suggest that the environment of the NICU is a little mistrustful, that we don't really provide those warnings. There's not a way for this baby not to be sort of in hyper alert. What's going to happen next to me? Where's my family? Where's that familiar voice? Everything seems foreign. And so how do we decrease that stress and help someone, our infants, get out of a chronic stress environment? So I believe that touch and massage can be very much touch, and only stroking as the baby tells us they're ready, and flows from the head to the toe and involves soft and non-mechanical ways. The picture at the right side of or left side of the screen is a mother in one of my studies who is actually providing touch to her infant's hands. You know, fingers and toes. Most infants, most parents, the very first thing they play with their infant is their fingers and toes. So helping parents in the newborn intensive care to have that same experience and to gently talk with their infant, provide that messaging, increase their attachment, work with their infant. And then this is another mother from our study, and getting them to participate in that. So it's a way to empower parents with good education about cues, using that cue based to decide, you know, how much touch, how much interaction can occur, helping parents to understand, read their infants' cues, and actively be involved in their care. Not the kind of play that you might have thought of when you first got on this call or this presentation, but the kind of play that really is where this infant is ready. As they mature, this mother, this is a little bit older baby at this point in time, you know, she has the baby in her lap, she's talking to that child, a little bit more interactive than what it might be early on. As you can see, we did have a phased in approach where we started with what I felt was the most natural, toes and feet, and then fingers and hands, and then abdomen. Sometimes the face is a little bit more sensitive, so really understanding what the baby can tolerate. You can see using whole hand, many times like these hands are just laid on the child so that they're not increasing the stimulation, they're actually providing some security for that infant. This chart shows how we were able to decrease the maternal stress, but we also had decreased stress for the infants as well. And now all I want to do is talk about recommendations for how we would implement. I did create both the PowerPoint to share with you as well as a handout that has recommendations for how you might implement. A lot of it though is based on really helping the parent to really understand their infant, you know, what can that infant tolerate, reading their cues and using those to increase and empower the parent to be increasingly involved in their care. We did use touch because we felt it was something, again, that the parent could, you know, this is their child, they could be involved with, even if their child was still quite ill. How do they provide good care along the way? So the next several slides are just recommendations for how you might implement and what it would look like. I'm not going to read those particularly. I thought at this point we would go into questions. And I did want to share some of the pictures about skin to skin because I do think you know, these are both pictures here. They're doing a heel stick while the infant's in skin to skin. So just because they're in skin to skin doesn't mean that we can't do other things that need to occur. Here, there's some vital signs being taken. And then here's a nice way to encourage interaction during skin to skin by using a mirror. So I'm going to go to questions. The last thing before we start is that the new developmental care, the 3rd edition, is going to be out on 2/1. So that's coming up really soon. We're really excited for the 3rd edition. The 2nd edition came out in 2010. So this is long awaited 3rd edition. So very exciting. So I'm going to go
wonderful.
back.
Thank you so much. So we can open up for questions, and there are 2 ways. One, you can write it on the chat, or you can go to the reactions on the bottom of the screen of the Zoom screen and raise your hand. So either way, it would be good.
I do have several questions from before that I thought I would start with while we're waiting, if someone has those, because there was, you know, I think in the pandemic, there's a lot of concern about 0 separation, about, you know, wearing gloves, what, you know, how wearing masks, what are we going to do about that? I wish I had better answers. I do think it's different. I still think that that parent's voice is very important to be with the touch and to warn the child. And I use, or to announce, maybe it's not a warning so much, to announce that this is mom or this is dad. And I really am here for you. And I really, you know, encouraging that active talk with their infant.
When I was in the NICU, I not only announced my presence, but I asked the nurses and everyone that would touch Zachary to announce that he was going to be touched, just the same way that we do in every other unit for any other patient in the hospital or in you know, in life. You know, if we're going to, you know, we give some, you know, like, prepare that this is what I'm going to do to you. You know, I'm going to change your diaper. I'm going to do a heel stick, and just, you know, the voice can be so soothing for these babies that even if it's not the mom, it will help.
Right.
Definitely.
And at least when that someone's near, someone actually put in chat that they've all long, and I'm sorry, you don't have a name, it's just like a number, 55x38, that they said that they've always advocated talking to the baby as if they were adults. And if you want to add to that, and then there's a comment in the chat, question, I guess, from the same person. Could it be that the negative experience of heel injections could be in part cause for the toe walking we see so much in infants who were born prematurely?
Yeah, it's hard to really talk about cause and effect, but there definitely seems to be a relationship. I don't want to say a cause and effect because we don't have the evidence to support that, but definitely the experience in the NICU are different. And definitely there is evidence that the neural pathways do change, where they can show increased nervation from that early experience when the neural pathways were developing. And so it seems like that increased narration, the increased synapses and even dendrites and axons would lead to increased sensitivity that could then be linked. So
another reason for the babies walking on their toes when they grow is because the feet are not flexed, right, Dr. McGrath? That if we let the babies like stretch, because they like to stretch, they just don't know how to flex. So if we don't flex them in the NICU, then that's what happens. when they grow, and it's very common. And now they're, people know why it's happening, so they actually flex the babies. That's why it's so important that we don't cover the babies when they're in the NICU and we can't see them, because every time they move, we need to reposition them to, for a more comfortable stay. So let's see what else.
There's another question from AC Holmes. AC asks, is there any current research or planned research to study the effects of adding playful activity with the touch, singing nursery rhymes, reading books, etc.?
There are some kinds of activities like that. The hardest part, of course, about all of those activities is that they're usually done in small studies in a particular nursery, so they're hard to generalize. But I think we're seeing more and more support. What I would say just kind of about any kind of developmental kind of intervention, which I think these could be put in that cup, is that so far there really haven't been negative effects. So if there's not negative effects, hopefully we can feel like they're more positive effects. We do know that there's a range of, we talk to parents all the time that we can't predict exactly just because this is a 24-weeker or a 26-weeker or whatever, how that baby's actually going to overall develop. We do know, though, that if the parents are there, that if they're receiving developmental intervention, their outcomes do seem to be better.
I went to the NICU, and I know we have several NICU professionals here, but in the conference they were talking about a study or a couple of studies that they did on reading with the babies in the NICU, and it was amazing because it was like you're not reading to the baby, you're actually reading and waiting for the baby to see if they were ready to continue, or and the mom will read like they do to a toddler. It's just so reading, we always say, the babies need to hear the voice of the parents, but it is so much effective when the parent actually listens to the cues to the baby. And the cues have changed through the years. I remember 20 years ago, if a baby put the hand like that, it would say, oh, he's trying to give you a high five. And Dr. McGrath, can you talk about cues of babies? We have a lot of moms in this this session, and several, it's not like what you usually think, like, oh, he's so happy, he wants to give you a high five.
Yeah, so yeah, definitely the displaying of the hand, kind of that worried look on their face, if their color changes, if their heart rate increases, those are reasons, with a younger baby, I might stop. I love the idea of reading and kind of pausing and watching. I always tell parents, even of young children, we talk a lot to young children. We don't often take breaks and let them talk. So, you really need to take that break and let them have the opportunity to kind of be responsive. I will see a baby who's very attentive, even a newborn, and it's like, just be quiet. Wait for them to do something, because they will do amazing things as trying to reach back out to you, because they want to continue. They want that interaction. And I think that can happen in the NICU as well, but you have to be a little bit more patient. You have to be very aware and present in that moment to really facilitate that interaction between the mother and the infant, or the father and the infant.
Mm-hmm. And many of these interactions can be done in skin to skin. It's not a secret, I am #1 fan of skin to skin care, also called kangaroo care. I remember, like, when I was with Zach, there were a lot of things that could be done in kangaroo care that even, and it was 20 years ago, And there are some hospitals that don't allow any intervention during kangaroo care. So, I wanted to see how we can increase it, and that's one of the reasons that I started Kangaroo Care Day, was to increase awareness of kangaroo care, and not only for the clinicians, but for the parents. I thought when I was in the NICU that I had to wait for the nurse to tell me that I could kangaroo care. So, that is not true. If the parent knows that she can kangaroo, then the parent can actually ask the nurse, can I hold? Can you help me position my baby in kangaroo care? So, it's interesting to see how things are changing, but some things are not. So interacting with the baby in kangaroo care is important, letting them move when they are awake, obviously, if it's possible. Kangarooing until 3 weeks, 3 months after their due date. Many of the hospitals stop kangaroo care when they are out of the incubator, right, Dr. McGrath?
Yeah, I do. I think it depends. I don't know that they stop. I think it's what they're encouraging more of and trying to help them do skin to skin. There, I did see there's one question in this. So I did use play and make it an acronym when I was using it for my research, because I really wanted to be able to call what I was doing the play study, because I felt that would be really good to help the parents be empowered to be involved. So play stood for parent delivered, loving, gentle touch, age appropriate, and your cue-based assessment. I know that's really wordy, but I really felt the word play was so important, because parents feel so like this isn't normal. Like they can't really do what they would normally do with their infant. They would be playing with their infant at home. They would be touching and, moving their arms and talking with them. And so I wanted to try and help normalize that interaction between the parent and the infant. And I felt the word play, because that's how we learn, particularly in infancy, was so important. And really getting back to, how do we normalize this interaction in some way, so that it really empowers the parent to feel like I have a purpose. I play with my infant when I come in. I can talk to my infant. I can do things. And so that's why I wanted to use that word, just really from a developmental standpoint. And so, yeah, I worked really hard to get an acronym to use play, just because I felt the word play and the way that we learn, and the play so normal, just felt like the right way to increase parent engagement.
And I think it's such an important word, because usually when we talk about play, you take turns, right? It's my time, and then if I play with you, I do something, and then you do something, and then I'll do something, instead of me doing everything. So that's why I thought it was a very, very good word. However, there were a couple of questions when, from the survey that we took when they registered, and it was, there is one that was talking about, how do you talk to parents and use the word play if play is something that equates to overstimulation in the NICU?
Well, and that's why I use the words age appropriate. So talking about what their baby is really ready for in play. What could we offer, and how do they watch, like the waiting for their infant to interact, like offering and then waiting, and offering and then waiting,
Right.
So that we can kind of see that dance, that play back and forth between the infant and the parent. I can tell you that the parents that participated, I have a really amazing little video of it. It was really like they really felt engaged with their babies. They really felt like they knew their babies, and they felt like that what they did was different than, providing care, providing other pieces of what was happening. So they were contributing in a different way to their baby's wellness.
A layperson, I could see that. And it would make me feel like there's some level of normalcy, right? Because other moms who have term babies, they play with their babies as well.
So yeah, and and I really caution anyone that it has to be age appropriate, it has to be cue based, it has to be coached, particularly in the beginning, so parents really become sensitive to what their baby does well with and what their baby doesn't do well with. And that idea of pausing and taking breaks and really, talking, and, we would stand behind the mothers and say, did you notice that? Well, what do you think about how your baby's acting right now? Do you think we should stop for a few minutes? We would talk quietly just to the mom and try and coach her through it. And we did a lot of coaching as opposed to showing. So not doing something with the baby, because we wanted the baby's reactions to be to mom and to dad, not to us. We wanted them to be the facilitator. So we did a lot of standing to the side and just giving them feedback, afterwards doing a little debrief to try and help them become the expert at really knowing their baby.
Yeah, one of the things with the NICU that it took me a while to realize is that, when babies go to the PICU or they go to any other unit, they have already been at home. So the parents know this baby, and they know that, they usually they ask the parent, how do you see your baby? But when you're in the NICU, you feel that, this is a new baby. I've never been able to have an intimate time with my baby. So that's why, my agony was like, how does he know that I'm the mom? If 150 people touch him, how does he know I'm the mom? And how does he know that I love him? Because I know I love him, but how does he know if, I allow these people to touch him and hurt him, and he doesn't know that they're trying to save his life. I abandon him every day. He doesn't know that, I can't stay. They kick me out. They kick me out at the night. And then when he's the sickest, I don't hold him, and I don't comfort him. So, touch is so important that, it's something that I always ask, like, a nurse that would say, you can't touch him. I'm like, well, why can't you touch him and I can't? I mean, what is the difference of your touch than mine? Mine can be comforting. I'll do it, very, very nicely and loving, and I have more time to touch him. And it was like, just hold your hands there, don't touch him, don't rub him. So, the idea of massage, it has to be something that has to be taught to parents, the same way that they taught me how to use my hands to, have the hands still over him to give him that containment, and, my scent and my warmth and all that. So.
Speaking of massage, Benedetta, do you feel comfortable sharing your comments about what you've been doing at your hospital in Genoa, Italy? Is she on? Oh, hi, Benedetta. Will you share with the group what you put in the chat?
Can you unmute? There you go. Yep.
Yes. Hi, everybody. Yes, I am a little emotional, and my English is not so good. So I try to explain what we try to do. I am an infant massage instructor and also trainer with the International Association Infant Massage. And we have this policy within IIM I found this policy. But I have to tell you that I fight against this policy. The policy is that baby during the hospitalization, during the hospital day, they need only positive touch. So in massage organization, they do a difference between positive touch, still touch, and massage. So the point is no massage after the discharge from the hospital is recommended. But I see what I saw Spain with the parents beside the incubators. Parents, they move their hands by themselves. So why to say they no, stop your movement, don't do massage? So this is what we find, and we so that from this came the need to show, to tell the people that the massage is safe. And we started a research recently. We have a student, it was her thesis. I will send it to Dr. Grath, an abstract of this thesis, because she's really studied how much this is safe. And she showed that it was only 9 cases, but that there was no distress signs and increased stability organization signs. So this is what the preliminary study. It's just for a few cases, but our intention is to continue the research and have more cases. I have a question for Dr. Grath, and it's how can we convince these doctors? So my question is about, they say that sometimes the cues are subtles. It means that it seems the baby is okay, but the parents, they cannot see for very subtle cues, and it's very riskful. So this is the risk, to do not get the subtle cues, and they maybe, I don't know if you understand me.
I do understand, Bernadette. And you know, the hardest part for your question is, I want to know when are we going to like really question every single medical procedure and say, well, why are we doing that? Or could we do that differently because of infant cues? Because we don't. And that's the part that really, like, if we're going to say this about positive touch and letting the parents touch in what I call the NICU is pretty paternalistic environment for the most part, how do we do this together? How do we justify all that medical touch and then not justify the parent touch? And I when you made the comment that the parents are stroking and yes, definitely. And I see that as well. But I want to help them do it better. And so I know they're going to touch. I know they want to, it's their baby. That's the normal thing to do. And so how do we help them know their baby? How do we coach them? How do we teach them good skills with being sensitive? And how do we help them take breaks, know when to talk, when to just sit quiet, when to, and really watch, how to be truly present with their baby and really understand what's happening. I just think there's so much precious information there. Because when I first started to really study this, one of the things that was said to me was, well, their hands and feet are so, they're very sensitive because we stick them, we do all this, we should avoid that. And I'm like, what, but what do parents do? I said, do they rub their hands and feet? Absolutely they do. So how do we help them do that in the right way? How do we help them realize, that development? How do we, I feel like, balance maybe some of that negative out so that different neural pathways grow, because neural pathways grow by experience. So, there's so much that could, if you really want to think about that neural pathway from a basic science study to kind of validate some of this work. It's so important to me to really think about it from a, long-term development, how much of what happens in the newborn care environment matters, not just for there, but for the rest of these children's lives.
I think another important part is when the parents themselves say they don't want to touch the baby. And that happened to me. The first time that I went to see Zach right after he was born, a nurse asked me if I wanted to hold Zach. And I was terrified. I said no. But I said, why? I said, I don't want to hurt him anymore. So the nurse said something that I always suggest everyone here to say to parents that are a little bit, hesitant. She said, you will hurt him more if you don't hold them. And in that sentence itself is probably what has me working on this for 20 years, because I realized that I was important for Zach, that there's nothing that there were so many things that I could do that nobody else could do. Not the best doctors, nurses, best equipment, best anything. There was something important about me, and also realizing, the superpower of calming that my mom has over me. I figured that, that I probably have the same thing with Zach. So, if a mom is or a dad are reluctant to do it, I think, pushing them a little bit of understanding why, because there is always a reason why they don't want to do it. I remember one of the moms that didn't want to hold, she said that, after a couple of minutes talking to her, she said, I had another baby and that baby died, and I don't want this one to die. So, it's just all this trauma that we have that, not just the trauma of the baby that is in the NICU, but, this trauma that we carry with us from our own life. So
I agree, Yamile. I think understanding why that parent is hesitant. Dr. J had the way of that when we were talking, was it last week, Dr. Jacqueline, that because telling me that not holding my baby would hurt him more would traumatize me and or make me argue with you. I don't know. I would vacillate between being in tears or upset. And I understand it came from a good place, but Dr. J has a way of wording it a little less something.
Yeah, so usually if I have a parent who says, no, I'm not ready, or, I'm hesitant, I will ask them why first to try and understand where they're coming from. But oftentimes what I'll do is, let me help you. Let me sit with you. I'll be here. I'll make sure that it's good. Your baby will be happier in your arms, will feel better there. So we need to help you feel better with that. So being there, reassuring them, when things don't go like the baby seems more stressed, helping the parent understand that they didn't do something wrong, that that we just need to take a couple more minutes and wait for this baby to settle, and not getting too distressed during that, and helping them to see the positive, because many times they watch us, the healthcare provider, who seems so very comfortable, and they really do feel they don't want to do anything to hurt their baby, and they see us as so very good at it, they can't imagine themselves being as good. And so helping them to understand that their touch is so very important to their infant.
yeah, I think that confidence is a word that I would use also. How confident you are, especially fathers. Fathers are terrified. I talk to fathers, and a lot of them say, I don't want anything bad to happen in my watch. I think my wife can hold, and then whenever is, we delay the introduction of this baby to the father because fathers are terrified. So I'm developing tools to help them, a kangaroo care device like the ZAKY ZAK, or the hands, or like the ZAKY hugs that I developed, I think is what made me, is pretty much from my own experience. I slept with Zach in the NICU when he was in skin to skin with, a couple of nurses that were right next to me, and it was probably the only sleep that I had. So, just doing kangaroo care, I think, parents have to do kangaroo care when they go to the NICU. Their number, other than all the decisions and all that, caring for their baby, giving them that intimate time with the baby, I think is so important.
I think, having a role, what if it's providing skin to skin, if it's reading, if it's touch, but having something that parents are responsible to do.
Right.
That this is your contribution to the outcome for your baby, helps make them feel engaged, helps them feel more important, because they feel we're very important, for their baby to live, and they decrease their own importance, and we have to help increase their importance.
Absolutely.
I love it. Lynn Bartz, I don't know if you want to share your comment, or if you're okay with me sharing it. I don't see her on, but Lynn had put in the chat earlier. Yes, I help families to write to their babies if they desire, and to a baby they may have lost. How can we support the family so they're ready to touch? This is something that can support all parents from her perspective. Oh, there's Lynn.
Yeah, hi. I'm just not in my professional gear today, and I didn't make it back to my office, and I'm in my car, so I was just feeling a little self-conscious actually with my video.
This is formal, so no problem at all.
Yeah,
Welcome.
well, thank you so much. I've worked in home visiting actually for 30 years in early intervention and in prenatal to 3 programs, in addition to my infant massage work. And all of this just like coming from the perspective after babies have often left the NICU. So much of this is resonating with me, which is part of why I started cuddling as a volunteer there. And it has been a very interesting process helping families write to their babies when they're pregnant. What I have learned through my work is that some parents have ended up having a baby in the NICU and having already written to their baby and read to their baby before their baby was born, helped the parent. They've shared with me parents feel more connected, and that has helped with their experience in the NICU because they have already worked towards that relationship and bonding with their families. So where I volunteer, a lot of families live really far away. And so sometimes they can't come and be as present as they would like. And so that's why the NICU where I am as a volunteer has chosen to offer families opportunities to record their voices so that they can be played for the baby pretty regularly, reading stories or singing their own songs so that the baby is starting to hear the sounds and noises from their own home. Siblings have engaged in that, which I think can just really help the whole family when they aren't able to be there with the baby. So
Thank you for sharing.
There's so much, Lynn. Have you heard of NICUs having music therapists?
Yes. I feel like I'm in a
I think it's phenomenal. I think it's
yes. The NICU where I volunteer, they have several individuals who have received their certification, and they are doing a lot of work specifically with families who have babies with neonatal abstinence syndrome, and really thinking about how touch can help to support both family and baby as they get ready to transition to home. And as an instructor trainer, I just really believe that as an instructor trainer, it's our job to individualize for our students. And so when I'm working with NICU programs, we really think about their specific program and what we need to tailor to make that work. So
Yeah.
it's just, I feel like it all goes together so much. And I'll just throw out Dr. Tiffany Fields. I've heard a lot of folks ask about research, but she's another person really with a lot of research related specifically to touch that individuals might want to check out a little more.
Most of her touch research is with not parent delivered. So the more newer research based on Tiffany's work is more parent delivered.
Yes, and what I actually just read some research that have really built on and thinking about infant massage assisting with postpartum depression, which really is a parent-baby kind of focus. I hear what you're saying. I totally agree with what you're saying, and I think she has helped to spark additional research.
Yes, I agree. Her work has been great groundwork for what could we be doing, and but I totally feel this is a parent domain.
Yes, I agree. And I would love to hear from you because I helped to plan a perinatal conference here in the St. Louis area and would love to have you at our next perinatal conference. So I'll be emailing you. Yeah, thank you.
Thank you. I really, that to me, and we were very intentional about, like, we were teaching the parents, we used a doll. As opposed to touching their baby, because we were intentional that they would only see and experience their baby reacting to them, not to me. Because I felt very strongly that sometimes that I'm not good at this comes out because they'll see a care provider who's very comfortable, very confident, and the baby does really well. And then the parent tries in their, sense of anxiety, not so much confidence, then the baby reacts differently. And then that sets up this not so positive interaction. And so we tried to avoid that we actually delivered any of the touch or massage, that it was all totally delivered by the parent, even when the parent was learning.
Yes, and that's the approach I think of the International Association for Infant Massage, and I know that it's our approach through the International Loving Touch. We demonstrate with a doll, and parents learn on their baby. So I love that matches. Thank you.
Neat. Well, I know there are a lot of comments in the chat that we won't be able to get because we are 2 minutes out, and I know we need to thank Dr. McGrath for her time and her sharing her wonderful research. Obviously, it's a hot topic, Dr. J, and there's just so much to learn from your work. Yamile, do you want to?
Well, so yeah, we got to almost at 12 o'clock, and well, I'm in Houston, so standard time. And I wanted to thank Dr. McGrath. This has been so amazing. I wanted to ask you if you can stay a little bit longer for those that want to stay, and if they have another couple of questions. I wanted to announce that we have our next session that is going to be on February 9th at 11, and everybody's going to get information about this. And we invited Mary Coughlin. She is a trauma-informed care expert. And the title of her presentation or her session is "Where is the Love? Getting to the Heart of Trauma-Informed Care." So everybody's going to be invited. We are so thrilled that everybody joined us. And can you write in the chat, is there anybody staying? Do you have any other questions, or we can close? And thanks everyone for coming. the handouts, you received all of them except one, which has the presentation of Dr. Grath, and the other things. So what do you think, Dr. McGrath? A couple of comments you want to share? Anything that we didn't talk about that that is important to touch?
I did share in the chat my email. I also, you did share the articles that we had shared too, because I do think there was one particularly about play in early childhood. And again, while it's not in the NICU particularly, I feel like that's a loss that we should be thinking about, that all of those concepts do apply to the NICU. And that's why I shared it. I do feel like the Dr. Hall's article from Journal of Perinatal Matology on the parenting neonatal intensive care unit is so important for us to think about. How do we increase parent involvement? I am extremely concerned, I guess, about how the pandemic is affecting parent involvement. There was a recent discussion I saw this past week, particularly as this next variant has been so high. It worries me about how we're justifying and making sure that parents are considered essential personnel. And as essential personnel, they're there and that they're still actively able to participate with the care of their infant. I hope that we can all continue to advocate for that.
And yes, Dr. J, we did, Yamile sent the pre-read, but what we'll do is we'll put everything together and resend
the recording as well.
And the recording and the link for the recording, because I agree, the advanced reading, for those who don't know, I like to play a doctor on TV. The advanced reading was wonderful. And Dr. J, thank you. There was so much. I just, we didn't even get into, we need to have her back because we didn't even get into how she talks about there being a consistency among the clinical staff, because one nurse may encourage mom to.
That is so important. That is to have one voice and that everybody, but when you don't, usually there is a nurse that really wants to take the time to teach. And so I always encourage parents to, if a nurse is reluctant to, to find one that is not, or, maybe just can't. But there are two trains of thought, and I talked with Dr. McGrath, and one is you cannot kangaroo because the baby's unstable, and the other one is the baby's unstable because they're not kangarooing. And Dr. McGrath, you want to talk a little bit about?
So I shared with Yamile and Marie when we were meeting getting ready for this meeting, a mother who had participated in our study, and this mother did live far away. So she would come and stay at the NICU for a couple days, and then she would go home, and then she would come back maybe 3 or 4 days later and do the same thing. So she was coming into town for her time in the NICU. And when she arrived, the baby had had kind of a rocky night where they had done a sepsis workup and several new IV sticks and things like that. So it'd been stressful. And the nurse who was caring for her son was a nurse she was familiar with, that she knew quite well, she trusted, she felt really good with, encouraged her not to do skin-to-skin holding because the baby had had such a stressful night, even though the baby seemed stable now. So the mom just stayed at the bedside and, put her hands on her baby, was there the whole 8 hours and really just was with her son, but did not do skin-to-skin care. at change of shift, everything changed. The new nurse came on. It was a new nurse who the mom didn't really know very well, had met, maybe didn't even have met, but someone she didn't feel as comfortable or secure with. And the very first thing after the nurse, got settled, asked the mother, would she like to do skin to skin care? The mother said, in my heart, of course I wanted to do skin to skin care, of course. But the nurse I trusted encouraged me not to. Now here was a nurse that I didn't know encouraging me the other way. And so the mother hesitated. And right away, the nurse started to educate her and try and encourage her, and not knowing why she had hesitated, or, really understanding why the mom was stepping back. And, the mom shared this story with me because she said, I want to do the right thing. And I don't know what the right thing is, because sometimes I get these mixed messages. And she shared with us, because we were kind of the consistent people, because she saw our study team on a very regular basis, probably more regular than she saw her nurses. And I always remember that story, because this was an incredible mom who was very connected. And so I tried to help her understand each of the nurses' perspectives. I said, well, possibly it could have been that it was, 8 hours later and the baby had been stable and now it's fine and you should. So timing. But I also do feel like, we're all learning about these interventions. Each nurse feels more or less comfortable. And sometimes the parent does have to be that advocate that says, I really have been holding my baby and this would be really good. Could we try? And, help them to have a voice with their caregivers. I think those are difficult situations, because I don't feel like either nurse was wrong. I feel like they each had good intention. They were each trying to protect the baby and do the right thing. It's a dynamic environment where there's a lot going on that makes it difficult. You can tell I'm not having a very good right answer, because there's not a very good
It
right.
depends on in the case, right? It depends
Right,
on
exactly.
every baby. We have to individualize the care for every baby, every mom, every day. Everything changes, So
Right. And I think helping her to understand that everything changes, and that it was 8 hours later and the baby had been stable all day. So maybe it was just fine then. And that was why she was changing, the plan, or saying maybe we should go ahead and try.
yeah.
So I do think, trying to really think about it as not being stable or static, that it's dynamic, that things are always changing, is important.
And stability change is it has a different definition for everyone. There are
Right.
some hospitals, and I think in the chat there was somebody that I can't find it, but that they do skin to skin in oscillators, and there are some hospitals don't even do skin to skin when the baby is on a ventilator. So it takes time, it takes a lot of training, it takes a change of culture, it takes neonatologists to support this type of work and this type of education for parents. There is a lot of thank you for sharing your email. And on the chat, and so it takes a village, it takes everyone, it takes volunteers, it takes the way that we welcome parents, the person in the front checking them in, everyone has to do something with touching the lives of these parents, so they are comfortable, and they work with you to get this baby as in the best possible way that we can. Does anybody else have any questions? I can talk forever with Dr. McGrath.
Well, I think we should find of Dr. McGrath's
But is
extremely
there
busy.
any other questions?
I know she's got a billion and one things. But thank you so much, Dr. J, for sharing your insights.
And thanks for staying a little bit longer too.
We very much appreciate that.
All right, so we will close, and we will see you. I like I said, I will send the last of the handouts, which is the slides of today's presentation, and I will resend the email. Can I share your email in that handout, Dr. McGrath?
Yes.
Okay, and then information about our February meeting and Kangaroo Care Day in May. So thanks everyone. Anybody has any comments? Any suggestions for next time? Anything?
Send us an email, please. Yeah.
Nobody. Okay, great. So thank you very much. And thank you, Dr. McGrath. You are a star as always.
It was great.
And oh, you know what? I want to share the information about the book. Also, can you send me that?
Yeah, I will send it.
Awesome.
Yeah,
It's
we
not on
just got the information that it would be just this week, that it would be out February 1st. So I'm very excited. I have not seen it. I've seen the picture of the cover that you saw, but that's it.
Awesome. Oh, how exciting.
Congratulations on yet another book. We'll have to update your bio.
Yes.
Yes, that's right.
I'm just glad it's done.
Yeah, it's a good feeling. It's a good feeling. All right. Thanks, everyone.
Thank you, everyone.
Bye now.
Okay. Bye, everyone.